and actually talk about how we take care of these patients. We'll look at both the emergency phase and as well as the time when y'all actually are taking care of the patients. So we know that the emergency phase begins with detection, and this is one of the big things we're trying to get out now is to the community in recognizing symptoms. And I know you all, when you do your education as far as patients are concerned, you emphasize them calling 911, because if you don't call 911, things do not work as efficiently as they would. So this is very important, the detection and just getting the EMS system all in line in order to deliver the care that we should. And, you know, I don't know if any of y'all have been down. Have any of y'all gone down in the ED and worked when they've had the backlog of patients? Oh, did you say you had? Okay. So you do know that they're becoming ICU nurses down there too, as far as assessment and everything. So what we have now is stroke on board, and then taking the patient to a certified stroke center. And we are actually, you know, if you are up in East Tennessee, above Knoxville, up in the Johnson City area and up there, do you realize they do not have a certified stroke center up there? They have one in Virginia across the line, but you have to come to Knoxville. That's over 100 miles. And then, but we're one of like 5 hospitals in Tennessee in this area that are actually certified to take care of stroke patients. The clock is ticking, and this is what is so impressive, is that every minute that we delay, we're going to lose a lot of neurons and brain cells. Now, grant you, we do have a lot of them, and we lose them every year. You know, they kind of go away as you get older. And so most of us, though, that as we age, we don't want to age more by losing our neurons or age faster. So it's very important that we save the patient's brain cells. Now, on your bibliography, I did not notice today if she printed the bibliography. If anybody wants a bibliography, if you're nerdy and want to look at it, I'll be glad to send it to you. I love to do research, and I see they did not print it for me, okay? But this Jeff Saver is one of the big people with the American Heart Association, and he actually wrote an article called Time is Brain, the Clock is Ticking. And it's very, very interesting. It's like 3 or 4 pages, but it just talks about the loss of brain cells and how it's affected by a stroke. Therefore, one of the things that you'll find here is that our neurologist, our stroke neurologist, which we have 3 of those, you know, Dr. Cerullatine, and then we have, who else do we have? Dr. Devlin, and, yeah, Pedionibus. Oh, okay. I don't know that she goes out, but Dr. Devlin, and of course when Dr. Sapkota was here, he went out all the time and worked with the EMS. And because one of the things they have found is that the EMS, if you do actually assess their ability to evaluate a stroke patient, you have to work with them in order to get their effectiveness increased. To identify the stroke. They're looking at everybody when they go out there, and everybody has different issues and things. So the better they get at identifying stroke symptoms and bringing the patient into a primary stroke or a comprehensive stroke center, which we are, the more effective is the treatment. Other things, too, with EMS, just a few things I'll point out, is that the American Heart Association, their guidelines are, of course, that the EMS keep the patient well oxygenated, that they, if their blood pressure is low at all or on the low side, is that they keep their head of the bed flat rather than raise them up, unless they would have acute breathing problems. Not to do anything about blood pressure. This is another thing that probably EMS years ago would stick a procardia, squirt it under the patient's tongue, drop the patient's blood pressure if it was up close to 220. And we know now that when you do that in an ischemic stroke, you take away blood supply and have more detrimental effect. Also, to check the blood glucose, we know that this is a big mimic of stroke, and if it can be treated, then a lot of times the symptoms will resolve. Give no dextrose solutions because that will precipitate cerebral edema, and keep the patient MPO. Two of the things we want EMS to tell us when they get here is when was the patient last seen well, and if they are on or have been taking recently, like today or yesterday, an anticoagulant. So just basically here is your symptoms. This goes along with that fast, the face, the arm drift, the speech problems, but there's also additional. If you'll add on a couple of these here, like vision and vertigo, you'll get pretty much the gamut of the most stroke symptoms. But we've tried to teach the public all of this, but you can have a fleeting loss of vision that would indicate that you may be having a TIA. So that definitely needs to be investigated, as well as vertigo and dizziness problems. Now, we are at this point, and someone told me that they were going to initiate again a week ago last Saturday, and I don't know if it's been done yet, having an app. It's called the Posterior app. And the EMS, when they pick up the stroke patient, they actually, on their phone, will hit this app, and it will send directly a message to the ED here, okay? And at that point, also, the neurologist will be notified, the stroke team. All of this is even going to augment and make the program better by getting the information here quicker and having us prepared to treat the patient. Now, one of the things you have to think about is stroke mimics, okay? Some people say, oh my gosh, we're going to give TPA and the person might not even really have a stroke. Well, I want to tell you something, that less than 0.05 people that come in that have a mimic and we're not sure, the CT looks okay, we go ahead and give TPA, will have any adverse effect because they have a healthy brain, okay? So if you have a low sodium, I think one of y'all, I think maybe Tiffany told me y'all got a patient with a real low sodium, and once you corrected that their neurological symptoms dissipated, right? So, but the patient got TPA, okay, with a low sodium, which can make your brain swell and cause you to have neurological deficits. This one here in the ED, no doc is going to give TPA and have a potential problem with bleeding unless you know what the blood glucose is, because it's so simple to do that to correct that you definitely don't want to do anything there. Post-ictal seizure, sometimes you haven't witnessed the seizure, the patient is brought in and maybe they have a paralysis, which is called Toff's paralysis, and you're not sure, you may go ahead and treat the patient and end up it was a seizure. Other things that will show up, most of these, the subdural hematoma, the intracranial tumor, those two things will show up with a CT. Multiple sclerosis, if they have a paralysis or something that occurs because of multiple MS, you really need an MRI for the most part to see that plaque or see the demyelinization or whatever's going on with multiple sclerosis. So you potentially could be treated there. Now, migraine, yes. You can have a complicated migraine and it look just like a stroke. So if it's a new onset, first time migraine, no history or anything, the person potentially could be treated for a stroke. Now, what you don't want to happen here is have a case that you bring in and you say, oh, it's not a stroke, we're not going to treat that. It must be like, and I'll tell you this story, and I hope I can pull it up, have a chance to to actually show you her picture. But did anybody here go to the Strikeout Stroke this year? Well, down at the ball field, they actually had a Strikeout Stroke, and Megan was there, this girl. But she's told her story a year or so ago out at Chattanooga State for the community education they had out there. And she just said that what happened to her was that she had been sick all night with a severe migraine, okay? And she had actually been vomiting and throwing up. And finally, she developed some neurological symptoms, and her mother called the EMS. And when they came in, they walked into the kitchen, and they saw on the counter a bottle of hydrocodone. Her mother had gotten up. You know, if you have stashed hydrocodone, got you a severe headache, why not, okay? Her mother had gotten it down for her and just set it there, okay? So when the EMS came in, automatically they said, drug overdose, okay? So what they did with Megan is they took her to one of our sister hospitals here. But they called ahead and they said drug overdose on board. So what do you think? It's just like when they say in MSICU, you're getting XYZ brought to you, your brain automatically starts thinking about how we're going to treat that person, right? So when they got Megan at the ED, she was, you know, still not comatose. So they had other more important people to take care of. So probably it was a couple hours before they finally worked her up and said, hey, you know, she's not a drug overdose. We're going to send her, she's a drug overdose. We're going to send her to Valley. So she went to Valley. And Valley did their workup, and they said, hey, she is not a drug overdose. We're sending her to Park Ridge. So she went to Park Ridge. So then, by then, you know, it's been several hours, and so there they said, wow, this is a drug overdose. I mean, this is a stroke. We're going to send her to Erlanger. So meanwhile, we were the 4th hospital she got to, okay? So that was a case gone wrong, but fortunately for us, and I'll tell you what we did for her later, Megan actually got treatment here and is today functioning quite well. Okay, she was at the Strikeout Stroke. Beautiful, beautiful girl. All right, so we know that we have to do the NIH Stroke Scale. This is level class 1 recommendation that patients have that. And I think we realize how important that focal assessment is in picking up on stroke symptoms. When they get here, door to physician, okay, actually, do you realize that we have given a thrombolytic? I think our fastest time down the ED is 5 minutes now. Now, how did that happen? It was because the EMS called ahead and got everybody on board, and they probably already had the medication mixed when they got here, okay? Took the patient straight back to CT, did the CT to rule out any bleed or anything, and then we're ready to treat the patient. But the Joint Commission actually gives us 10 minutes here for the patient to be seen by the patient when they get through the door downstairs. But whenever our docs hear that the patient's coming in, they go straight back to CT. So everything, is quite rapid. They get the stroke team together. The CT is usually completed in much less than 25 minutes. Door to CT read, well, the neurologist is back there, right? Reads the CT. So that 45 minutes time is decreased tremendously. The NIH, before any treatment is done, you've got to have that NIH stroke scale documented, because otherwise that substantiates why you're treating the patient. Door to thrombolytic, less than 60 minutes. I think our average time now is under 30 minutes, or around that, or 35 minutes or so, that we are able to get all of this done, get the CT, do the look at the patient, do they qualify, is there any exclusions or whatever, and get this done. So they should be up to your unit well under 3 hours from hitting the door. Okay, and we're just doing that good a job. Blood glucose has got to be documented. All these other things here, You do not really have to have the results of them. What about coagulation? At one time, a few years ago, like 2 or 3 years, I remember sitting up in the meetings for the neuroscience meetings, and the big thing was the lab. Okay, why couldn't the lab get the coags done quicker? How long does it take you all, if you send down to get an INR, how long does it take you to get it back? How long?
Did they lose the blue top?
Did they lose the blue top? Okay. Would you say it'd take at least 30 minutes minimum? Oh, you're saying, oh, yeah, you mean longer? Oh, okay. Well, remember, time is brain. And let's say they do better in the ED, and they can do it in 15 minutes. Do you know what? Time is brain. Okay? So unless you are on an anticoagulant, you took it that morning, then you had a stroke, or if you're on a novel, one of those new anticoagulants, you cannot even do a lab on that anyway. It's going to exclude you, okay? But they're not going to wait on this unless there's some reason, like they're on warfarin or they're on, where they can actually check it out, okay? Even if the ISTAT, I'm not sure if the ISTAT's that accurate or whatever, but they don't use it down there for coags. No, okay? They just go ahead, unless the patient's on the anticoagulant already, warfarin, and they have to wait for it to come back then to see what the INR is, okay? But other than that, you're not going to wait to do the thrombolytic. So all this stuff here, you don't have to have any of it, okay? So stroke history, time last known to be well, okay? So we know that you can give a thrombolytic up to 4.5 hours. So the last time well would have been the last time it was witnessed. And sometimes you have to do a little bit of investigating here, because if the patient, you remember hearing them up to the bathroom walking around, like my husband, he gets up and goes to the bathroom at 6 o'clock, okay? So if I knew, and you after years of this, you know when the commode's flushed, the tinkling goes on and everything, because it wakes you up. All right, so an hour later, if you find him in the floor, the last time seen well was probably at 5 o'clock when he got up, when you glanced at the clock and realized that he woke you up going to the bathroom. So you could differentiate that. If you found him in the floor an hour later, you know that the time frame, what the time frame was there. Okay, so anyway, that's important to know. And what medications are currently on, particularly the anticoagulant therapy, okay, because those two things are going to drive the treatment. So these are your priorities in the ED, is determining, are the symptoms, do they have symptoms of a stroke, the exact time of onset. Now I want to explain that a little bit more as far as therapy, because we can treat this patient without actually knowing the exact time, just with our technology, our radiology technology now. But differentiate ischemic from hemorrhagic, and that just requires a CT and then administering treatment, the TPA or other interventions. And of course here we have all this endovascular therapy. TPA is just, for the most part, on a large volume stroke. And by that I mean one that wipes out one side of your body, takes out your speech, and I mean just a big stroke. And we'll go over some of those in a minute. Those right there, TPA is not going to usually touch it. We have to do the endovascular. So here is really on an outlying hospital, let's say in Dayton, they get the patient in. The patient has stroke symptoms. They do the CT. It looks like this, nothing, no bleed. That's all they have to know. And if it looks like this, you take another avenue here. You're going to send the patient directly to bring the patient into Erlanger and send them to your ICUs is where they're going to go if they have this intracerebral bleed. But this right here is all you have to have as far as radiology to give the TPA, because you're not having a bleed, but you have stroke symptoms, so you know that there's an occlusion there, a blood supply. Now, here at our hospital, we'll do the CTA, okay? Now, I grant you right here on some CTs, you can see this density here. that would indicate a occlusion to the middle cerebral artery. You can't always see that clearly, but sometimes you are given a clue there. But no bleed, but here you see where it's cut off completely. Here's your middle cerebral artery. It's patent there, but here you have no blood supply here, okay? So we know then they got a large vessel occlusion. This patient, even if they've had TPA, will no doubt need to have someone to go in and retrieve a clot from right there. So what we're really trying to do is salvage all of this area here. This is dead, okay? Already dead, and the stroke has occurred. But you have an area out here, it's called the penumbra. If we can recanalize and open up this blood vessel, then we can salvage those other neurons there. So we not only do a CTA here, this just happens to show a dissection down here, but we can do a CTA that will show the artery that's involved. But we also do a CTP, CT perfusion. It can show you the size of the core that is completely dead, okay, and then how much viable tissue is present around that core, okay? So if you have a small core and a large area of viable tissue, those are the ones, from what I understand, and Dr. Baxter is going to come down and talk in a little while, so if you have any questions along this line, please ask him, is that this would be like a wake-up stroke that you did not really know when the patient was lysine well. Maybe you knew except for the night before, and it's too long a period between lysine well and actually to give the TPA. But for this, they can determine with CT perfusion how large the core is, how much viable tissue is there, and then make the decision on using endovascular therapy. So you're going to see more of that as we move along and all this evolves as far as the treatment. So like here is the core, and then you have the viable tissue out here. So you could do the CT perfusion. What is the problem with the CT perfusion? It's probably the dye as much as anything. So you want to keep, that's why when they come into the ED, they a lot of times will drop in a liter. They usually drop in a liter of normal saline. That helps to dissolve the clot, but also helps to perfuse the kidneys to offset some effect of the dye that's used. So we have diffusion, perfusion, mismatch. So here you've got a core that size, and then all this other area here is viable tissue that you're trying to save. Now, MRI, it's a normal one. Over here, of course, you see the hemorrhage that's occurred there. But actually, an MRI is really the gold standard for determining and showing the stroke that you've actually had. But it takes time to do an MRI. So can you imagine us trying to do an MRI on everybody that came in with a stroke downstairs? Would not work. It takes too long. I think the fastest you can probably do an MRI is like maybe around 30 minutes or so. And I know at Johns Hopkins, when I was up in that area, some of their nurses were telling me that they were using MRIs. And I thought, well, you have to weigh the length of time it takes to do it versus getting the recanalization. So I don't know how that's going to play out. Now, as far as strokes are concerned, you have most of what you're going to see here is ischemic strokes. And these are because you do not have enough blood to the area. It's thrombotic or embolic. Otherwise, it's an occlusion like this where you actually have clot formation in an artery, thrombotic, or you have a clot that moves from one area of the body to the other that forms and occludes a vessel, a blood vessel. So this is what causes your ischemic stroke. Again, looking at the ischemic area here and the infarct, dead tissue, and all this is still viable. The sooner you recanalize, the better outcome for the patient. Now, time is brain. Not only you have that occlusion with decreased oxygen, but it sets off a cascade of events when you have ischemia. And, you know, you have normal neurotransmitters like gluconate in the brain. You have norepinephrine. You have a lot of different acetylcholine. You have all these neurotransmitters. Well, when you have this happen, you actually end up having excessive amounts of excitatory chemicals, and so that causes more damage, some of these things that occur. So the biochemical cascade causes more damage. So the quicker we get it open and recanalize, you're going to have a decreased amount here. So let's talk about a few of the stroke syndromes that you'll see. One of the biggest strokes you can have is where you occlude your internal carotid artery. Now, grant you, if this is slowly over time, because of the circle of Willis, the internal carotid artery on the opposite side may provide enough blood supply here that you will not have a stroke. But if you just all of a sudden acutely occlude, and maybe you have plaque there that ruptures or whatever, like a coronary artery similar, then just quickly occlude here this internal carotid artery, then you are going to have a major stroke. And this would include total paralysis, could include total paralysis on the opposite side of the body, the arm, leg, and face, okay? And if it was on your dominant side, which for most people it's in the left hemisphere, then this is the person that could get that global aphasia even, where they didn't understand the spoken word or could not express it either. If it's on the non-dominant side, these people are likely to have that severe neglect, not recognizing the opposite side of their body. One of the things that can occur, and I know when I was down at Workforce, somebody walked in there and said, you know, I'm having this bleeding coming and going on my vision in my right eye. I said, wow, we're not here to treat that. Maybe you just need to head on down to the ED, okay? That could be what's called amaurosis fugax. Isn't that a beautiful word? But it's French for, it's when you have an occlusion in your internal carotid artery. It cuts off the blood supply to your ophthalmic artery, and that can cause you to have either a visual field defect in that eye or maybe fleeting visual changes. And so it could be a TIA, I mean a warning that a big stroke is going to occur. So that's your carotid, internal carotid artery. Now, so when the person comes in, of course, you can look at the carotids either through like a CTA or an arteriogram. They may initially just use an ultrasound to depict how occluded it is there. But if they have that large volume stroke here, they'll go straight to, they'll probably send them straight to specials, because that big a stroke like that is going to require some endovascular intervention. Now, the middle cerebral artery, I like this because it shows you the different areas that can be occluded. Okay, so here's your internal carotid artery, and it feeds your middle cerebral artery. And sometimes you'll get a patient in, and if you read their CT or their arteriogram or whatever, it would not show up on a CT, but it had to be a CTA or an arteriogram. It will say they have an M1 occlusion here, or maybe they have an M2 occlusion or an M3. So if your interventionalist is going in, they can come up through the internal carotid artery and go in here and actually retrieve a clot that's laying in this area here. Notice here, if you completely occlude this artery, you've cut off blood supply all the way up through here, okay? So this is what you're going to have. If you have that complete occlusion, here you have this much of the hemisphere that's involved, okay? Now, earlier we showed the area here in the motor cortex that innervates your extremities on the opposite side. So notice here, paralysis of the arm is greater than the leg. Your leg up here is actually supplied by the anterior cerebral artery. So most of the time, if you have a middle cerebral artery stroke, you're more likely to have a complete paralysis of the upper extremity. These people may have a weakness in their lower extremity, but for the most part, it's going to get that upper extremity. If it's on their dominant side, which this is the dominant side, left, you can have Broca's aphasia, expressive aphasia. You can also have interpretive aphasia here. But, and if it's in the non-dominant side, you get into those problems with extinction and neglect again. Now, looking back here just a minute, for the most part, if you have a complete occlusion, if they can go in and remove that clot, you're going to probably diminish remarkably the amount of symptoms the patient has. But realize that you can have an occlusion that goes all the way up here. The occlusion is here, and this is still open down here. So you have different, if you have a middle cerebral artery stroke, it doesn't necessarily mean that it is it's according to where it's located, if it's an M1, M2, or M3 as far as the severity of the stroke. Now, for the anterior cerebral artery, this is the area that is the blood supply is to here. And notice here, that's that frontal lobe. So remembering all the things we talked about, executive functioning, ability to delay satisfaction, goal setting, all of that, when you have that middle cerebral artery, the anterior cerebral artery occlusion there, you're getting that frontal lobe. Okay, it's much like hitting your head with traumatic brain injury. Similar symptoms can occur. Now, up there, if you notice, the main area, the foot, was right up here in that motor cortex up here, up in this area here. So these patients are more likely to have a paralysis of the lower extremity. Also, in the frontal lobe here, you have these primitive reflexes. So if you have a patient that has a real severe anterior cerebral artery stroke and comes in a comatose state, they're the ones that's going to have the like a sucking reflex, the grasp of the hand, like an infant would have. These primitive reflexes may show up. Abulia is a word I like because I actually was really shocked one day when I didn't know what that word meant. Do y'all remember what it was? I think I might have gone over it last time. Maybe I didn't. But I was at the beach reading one of my books on neuro, sitting outside looking over the water. I didn't even take one with me this time. But anyway, it said abulia. And I said, well, what is abulia? So I looked it up and I said, oh my gosh, I have abulia. It's inertia, not able to make decisions and that sort of thing, okay? But that's what happens with these people. They get kind of apathetic, and so it's a frontal lobe issue. Bowel and bladder incontinence, like I mentioned earlier, the frontal lobe, you actually control at a conscious level, whether or not you need to go to the bathroom or do not need to go at certain periods. And if you have a frontal lobe issue here with the anterior cerebral artery, then you may get issues with that. Okay, now what about a watershed up here? One of the things that they went over at the International Stroke Conference this year was there was a discussion on to keep the patient flat after like an ischemic stroke or raise the head of the bed. Think about it. So if you don't have enough blood up there anyway with an ischemic stroke, you would think you'd want to keep them flat. But I think it's still up for grabs. I mean, they wanted us to enroll in a study where we kept half of our patients flat and half of them rolled up, okay? But we didn't enroll in it. Of course, I couldn't have made that decision. I'm not the one involved, but it would have been something that might have been interesting for y'all to have done. But the watershed area here would be something if you did not get enough blood supply up there for some reason. And let me just go back here and show you. Right up here is the end of the line, right? That's your middle cerebral artery. And then your anterior cerebral artery, the end of the line is over here. So for a watershed stroke, you have to get decreased amount of blood supply in these areas here. Well, think about you guys in medical. I mean, you take care of septic patients all the time. Has there ever been a time when a patient was changed neurologically after their blood pressure was gone south on you for hours and you couldn't get it up? Guess what? They probably had a watershed stroke or something like that, okay, because they did not get enough blood supply up there. So this is just particularly this zone here between the anterior cerebral artery and the middle cerebral artery. So back to positioning is ischemic stroke. Anytime your patient's blood pressure does start dropping on you, and even maybe getting down to 130 or whatever, if they're breathing well and they don't have any compromised breathing where they have to sit up, then lowering their head may improve their neurological symptoms. Now, what about the vertebral artery? If you look through here, we looked at the brainstem and all of those cranial nerves that have to do with speech, dysarthria, dysphagia, swallowing. We talked about the trigeminal nerve that is in the brainstem, having pain in the face, nose, or eye. That would be that nerve. What about nausea, vertigo, and tinnitus, the 8th cranial nerve, the vertebral, for the vertigo and everything. Nausea could be your brainstem, your medulla. All of this, all the numbness or the weakness of the face, the facial nerve, diplopia, homonymous hemianopsia, having to do with double vision and visual field effect from those cranial nerves that have to do with vision. So you do not see on this, one thing you do not see here is anything that has to do with cognitive function, okay, processing, okay, and staggering gait and ataxia cerebellum. So if you have a patient here that has symptoms related to this, you can pretty well say that it's brainstem, okay? I mean, you can tell by looking at them, they understand what you're talking about. They follow commands. I mean, if they can't move something, they'll make at least, you can determine that. But they have issues with these other areas here. So the basilar artery locked in is a very severe stroke too. Now, if you're locked in here, you have an occlusion in this area here. So you actually cut off the blood supply to two motor areas, sensory tracts, that go to your extremities. So a locked in is a quadriplegic situation. But basically, a lot of times these patients still, they can breathe on their own. It's a little different than a quadriplegic like a C2, 3, or whatever. But they can breathe on their own. Sometimes they have a trach because they can't handle their secretions very well. But they can usually maybe open and close their eyelids, okay? But other than that, you can look at them with a basilar artery and you will see that they are there when you look in their eyes. You probably won't happen to you more than once every 50 years or so, but sometime you're going to walk into a room to do your assessment and you're going to realize this patient is there. He cannot move anything, okay? And a basilar artery. Here was your book that I really recommended if some of you were here before that you buy and read or see the movie. But is John Dominique Bobby. He had a basilar artery stroke when he was 39 years old. These are his two small children right before it happened. And he was actually an author and a editor of a large publication in Paris, France. And when he had his stroke, he cannot move anything except his eyelids. This eye was sutured down because of it did not close well, so he was getting a corneal ulcer, so they just sutured it closed. His left eyelid, he can move. Okay, that was it. That's all he could communicate with. And this is his speech therapist. She developed a way of communicating with him with the alphabet and everything, and they wrote this book together. It was his book, that he wrote. It's called The Diving Bell and the Butterfly. They made a movie of it too. But it really, what it does, it tells you about the inner thoughts of someone that's completely locked in. Has no way of communicating except with their eyelid. It's quite surreal, but good book to read. Now, posterior cerebral artery, moving on to that, if you notice, I just highlighted the temporal lobe and occipital parietal area here. So your biggie here is these patients are going to have problems with memory, just like I was talking about the patient where they removed part of his temporal lobe and hippocampus. They cannot have problems making memories. They can have different problems with the visual field effects because of the occipital area, and also their visual pathways. So you'll see different presentations here, but now you're dealing with the eloquent parts of the brain again as far as processing and memory, etc. So you'll see those types of deficits here. One of the things you might find, and sometimes it's rare, that you may see is called prosopagnosia, where the person can no longer, after having an occipital lobe stroke, cannot see faces anymore. There's one little part of the brain that actually allows you to see somebody's face. Is that not amazing? I just don't think we could have just happened. It has to be a plan out there for the way we were made and everything, because that in itself is amazing to me. Palinopsia, I had a patient that actually had a brain tumor in the occipital lobe, and the reason she had gone to her doctor is she was an accountant, so she read numbers all the time. So she'd come down one column here and then go up another column. And when she came down one column and went on to another column, she's still seeing the first column. You take it for granted that it goes away when we're reading or something like that. But it got to be very annoying to her. She couldn't work. And she had a tumor in her occipital lobe, was what was causing this palinopsia. So, disorders of reading, color, a lot of different things can happen with cortical areas within the occipital lobe. Now, this is an interesting, again, if you look down at the posterior inferior cerebellar artery, if it becomes occluded, here you'll look and you'll see that this is also called Wallenberg Syndrome. And if you look down through here, again, you're not going to see problems with the eloquent parts of the brain, the processing, the executive functioning, that sort of thing. What you see is problems with swallowing, voice quality, dysphonia, okay, problems with speech. And you will see some problems with pain and temperature sensation, but the big ones are the cerebellar signs, ataxia and vertigo, and then again the medulla, nausea and vomiting, and hiccups. There's a part really in the brainstem in the pons. I don't know if you've ever had a patient that just had hiccups a lot, but that can mean that that's being irritating to the area of a brainstem when you have hiccups. So this is called Wallenberg's. Another symptom that you will not see often, but you might sometimes, is called Lacunar Syndrome. And this is where when you're checking pupils, you'll notice that one looks pretty normal, but the other pupil is real small, okay? So here you have a normal pupil, but over here this one's smaller, and also you have a little bit of ptosis of the eyelid. Well, what it is you have a nerve innervation from the sympathetic chain that goes to the eye. If you go into a dark room, your pupil will dilate, okay? If you get real excited, fight or flight, your pupils get large. That's the sympathetic nervous system. Well, with this type of stroke, you have a blockage of that sympathetic innervation there. So it's called the Horner sign or syndrome, where they have the smaller pupil and their eye looks abnormal, kind of drops back, okay? And I'll refer to it again in a second when I talk about dissection. Here is lacunar strokes, blockage of the small penetrating arteries. That's right here, here, here. Okay? When you get a blockage there, you may not have a huge stroke, but you may have numbness in an area of an extremity, or there's different kinds of syndromes like maybe your hand, it's called the clumsy hand syndrome, or it may be in the thalamic area if you have a that may make you drowsy or may interfere with the motor sensory pathways that goes through the thalamus. But a purely sensory area like a numbness in your leg or your arm that's related just to those pathways that lose their blood supply. Now, dissection. Okay, this is a huge dissection. We had a guy that was up on North Wing 7 and that we had, I remember walking into the room and he has a helmet on, okay, on North Wing 7. I thought, well, this isn't good. So, no, what had happened, he had actually been a roofer, very physically fit, okay, and he had come home and had some issues with his neck or something and gone to a chiropractor that day. Did y'all take care of him? Do you remember? And then after that, he went out and jogged or something, but came in that night, sometime during the night, and was having some problems speaking or whatever. And then his wife did give him an aspirin, which may not have helped him. I think it probably did in that situation. She didn't know if it was a bleed or what. They just gave him something. Ended up, though, when they brought him in, he was out of the window pretty much for treatment, okay? He had a dissection of the carotid, internal carotid artery. So sometime either roofing or going to the chiropractor or whatever, he had dissected his internal carotid artery, and then from there, this clot had moved out and completely occluded his middle cerebral artery, and from there, he had an evolution of his stroke and developed all that cerebral edema and everything that can happen. And he had the helmet on, of course, because he had a craniectomy. All right. But here he is, 40-something years old, and had this huge, huge stroke. So Horner syndrome, if you looked at his pupil there on that particular side, you would see that small pupil. This is another time that the internal carotid artery feeds the sympathetic chain, and you can get the Horner syndrome, the small pupil, a headache, and actually pain in the neck would be a pre-sign before you had a big stroke. If you were going to dissect your carotid artery, you could have a small dissection and have these type of symptoms. Okay, so moving on here. I hope they'll come and do our presentation at 12:30. That would be awesome because I'll probably be finishing up this section in just a little bit of time. But we talk about treatment. And in 1996 actually was when TPA was discovered, you know. And this thrombolytic, it's taken it 20 years now really to get started and be utilized a lot. People are so afraid of it. And this, I guess when you look at this, you have 100 people, and this is the initial studies. Actually, we do a lot better here as far as complications. But here you have, if you give TPA, a thrombolytic, within the guidelines, and you give it to 100 people, then you're going to have this many people that their symptoms resolve. And when I say resolve, I mean they go back to normal or whatever, you know. Again, they may still have a little issue as far as a new brain, I don't know. But from what we can observe and assess, if they had a 10 on the NIH Stroke Scale, then they go back to 0, okay? That's these people right here. These right here get some improvement. With these, we see nothing. Now, probably with this right here, it's going to be a large volume stroke, a large vessel stroke, because with large vessel strokes, you need more than TPA anyway. But this right here, out of the 100, you'll have 6 people that either die or become more severely disabled. Okay, So if it was your grandmother you brought in, do you want them to have TPA or not? At our hospital, we actually, instead of having a 6% here, we actually have our bleeds from TPA are more like less than 3%. So we even do better here. For the reason that we get the patient in, we evaluate them very quickly and get the TPA. The quicker you can give TPA from the last seen well, the better you're going to do. So anyway, it's still underused in some hospitals, I'll just tell you that. Now, the FDA actually says we have 3 hours, can receive within 3 hours of onset. That's the FDA, what they say in relation to TPA. But the Joint Commission, the Europeans have done studies on this to saying that it is effective up to 4.5 hours. So you can give it from last seen well to 4.5 hours from that. The longer you wait, you're more likely to have a bleed, okay? Because here you got a stroke that may be evolving, okay? And the larger the stroke or whatever, the more likely you are to have a bleed. So, and you're also less likely to have good outcomes, period, the longer you wait. So if you can get it under 3 hours, or maybe even like within an hour of when they had their symptoms start, then you're going to have a better outcome. Now, I do have intra-arterial, but we were just talking about this earlier, that for the most part, we don't use intra-arterial here. We got other better interventions. So what is the criteria here? Let me go on. I've got another slide here. I will say you should be 18 years of age or older and within the time frame of no greater than 4.5 hours since last seen well and a negative CT scan. And this is the only radiology workup you have to get TPA. You can get these things, but you don't have to have the result back for the INR or anything unless you actually have a bleeding disorder or if they're on a something like warfarin. Now, this is the 2015 new guidelines for TPA. That's what I was trying to move on to. The age is the same. The time frame within a 4.5 hour and non-contrast CT showing no hemorrhage. This is your inclusion. Your exclusion. If they have any evidence of bleeding on the CT, okay, suspicion of a subarachnoid hemorrhage. I mean, it's the worst headache ever. I mean, there's different things there that tells you that they may have a subarachnoid hemorrhage, but it's going to show up. It should show up with a CT if it's been within a certain period of time. Intracranial surgery or head trauma or stroke within the past 3 months. When you've already had a stroke, say 2 months previously, your brain is not healed well. It takes like up to 3 months for your brain to really heal well after a trauma or after a stroke. So you don't want to give TPA during that period. Active internal bleeding. If it's anywhere you can't stop bleeding, then that would be off limits. Presence of intracranial conditions that may increase the chance of bleeding. But this is should show up. I mean, if you have a neoplasm, you should be able to see that on a CT. Severe uncontrolled hypertension. If you can't get that blood pressure down within the guidelines, then they're not. The higher the blood pressure, the more likely they are to bleed also. And bleeding diathesis. If you know what their INR is, if it's that we have said before greater than 1.7, you don't give TPA. That might be negotiable. So this time they haven't actually put specifics on there. They just said if there's any problems with coagulation, it should be questionable as far as giving the TPA. So look for a hemorrhage and then get the blood pressure under control. It should be probably lower than 185 systolic and lower than 110 diastolic, okay? One of the things down the ED that they'll do almost immediately with a high blood pressure when the patient comes in is go ahead and put them on a nicardipine drip. I'm interested in you all that are in ICU. Have you used this drug yet? Okay. I want to know about it. I want you to tell us about it.
I have used it a time or two. I don't really know a whole lot about it, except it's very expensive and it's hard to get. Had a patient when it ran out, the pharmacy couldn't find any, and called around to several hospitals, couldn't find any there, so we just kind of power weaned the patient and went to cardine.
Oh, okay. So cardine is your standard anyway, for the most part.
The
Well, the Cleverplex actually was presented at the International Stroke Conference. They were really big on that, so I was just seeing if we had already interfaced it. It works really quickly, doesn't it?
Yeah, it's like tiny balls.
It's a tiny balls and everything. But when you use it, is it it's effective, would you say?
Yeah.
Okay. You can't get it.
Work any better than the cardine.
Okay. It's no better than the cardine. All right. Just wanted your input on that. Okay. Now, of course, you all in here do not have to know about mixing TPA or anything, do you? Because for the most part, you're not going to be giving it, I don't think. They'll give it in the ED. But this is your dosage. You never give more. Even if a patient weighs 400 pounds, the maximum dose is 90. Yeah. And you don't want to try to increase it. And then you give a bolus. We have a little calculator that you can use. It's all laid out. 10% of the total amount is given over a minute, and then you give the rest over an hour. So probably they're going to be, as far as I know, they're not sending them on up to you all before they have finished their infusion. But, they do start it like out east. They'll start the TPA, put them on an ambulance, and send them over here. So you all might at some point, if they're going to bleed, they can still bleed after you get them. I mean, it doesn't necessarily, most of the time the bleeding's going to show up earlier, but you'd stop the TPA, of course, and we do, if it's, then you can give reversal medications like cryoprecipitate or fresh frozen plasma to correct the bleeding afterwards. Now, we have to really monitor the blood pressure, and you all are still taking care of that patient after you get them. But during and you have to keep the patient's blood pressure below 180, below 105 during TPA infusion. And then afterwards, of course, you don't want it actually to become very high after that too. But these are just things to monitor during that 1 hour afterwards. All of us, when we're taking care of the patient, and this is big for y'all, is to monitor their intracranial pressure afterwards, because if they're starting to bleed, that's where it's going to show up. Now, another thing you might see, but it's usually, again, this should occur within the first 10 or 15 minutes after the TPA is started, is called oral lingual or angioedema. And there is a correlation here, I think, and they're looking into it in more depth. We're given so much more TPA now. But patients that are on ACE inhibitors, one of the side effects of an ACE inhibitor is oral lingual edema, right? And y'all have probably seen it. Yes. So if you already have a patient that's on or being allergic to that, and then you give them TPA, those may be the ones that are more likely to develop this edema around the mouth. But anyway, these are some of the ways you can treat the patient. Hopefully you'll pick up on it early enough to stop the TPA and not have to intubate the patient for airway compromise. Now, during the TPA, while you're doing it, every 15 minutes for 2 hours, you've got to do the neuroassessment and the vital signs, okay? Then every 30 minutes, and then every hour for 16 hours. Is there anyone in here that is not familiar with this little piece of paper? Okay. You should have one in your kit. Are you on the floor, or are you, okay. Probably you're not going to have to use it on the floor, but it actually has simplified measures. Do y'all not like it?
Yeah.
Okay. You better say you like it. Okay, so I'm reporting everybody.
I love it.
You love it. Okay. Actually, what we were doing between the ED trying to interface computers and everything, it wasn't working as far as showing the assessment of the patient, how it was being done, because they'll probably do, at least with the way they've been having to do it in the ED, you all may not get the patient until the 16th hour. I don't know, sometimes. They've actually had to keep patients down there. But this is like every 15 minutes for 2 hours and then every 30 minutes for 6 hours. You've got to do that neuroassessment and the vital signs, okay? And then every hour, I think I skipped ahead, every hour for 16 hours. Now, whenever you all have a patient with that comes in, and the basic care at this point, all I've talked about so far is TPA. But you do realize that a great number of our patients are going to get endovascular therapy. So those patients we'll talk about separately shortly. I'll talk about them in a different way. But up here, the best demonstrated practices, everybody should recognize this now. This is what the Joint Commission says we have to do in order to actually have our certification, for one thing, but also to make sure we have good outcomes for our patients. So we have people that gather data and actually look at charts to see how many of our patients, out of those 2,000, they do a sample actually, but out of over 2,000 patients, how many of them had the NIH Stroke Scale documented before they had intervention for stroke. Okay, that's huge. Also, these are just good practices as far as good oxygenation, positioning the patient accordingly, etc. But dysphagia screening on there. How many patients had their dysphagia, their swallowing assessed before they were given anything by mouth? Okay, these are other things that are just good practices as far as intravenous access, making sure that they have good volume as far as their fluids, and avoiding any dextrose solutions. These are not things that we have to get data on, but are good practices. So deep vein thrombosis, actually the prophylaxis there, I've even talked to the ED people, they've kept their patients your patients down there so long that they're having to put DVT, the sequentials on before they send them up, okay? Now, going over the list of different things that are on the chart, some of y'all have heard this a million times, I know it's old stuff, but one of the things that they did discover is that patients have better outcomes, if a stroke patient, if their temperature is kept pretty much normalized. So if you have a patient that has a temperature of 99.5 or greater than 99.5, they should get Tylenol, okay? What does it say on your stroke? Yeah, it says that on the acute stroke, doesn't it? So, I mean, you're probably still like, why in the world am I worried about a 99.5 or 99.6? It's just that has been the outcomes that's been showed up there, okay? Another thing that we have to make sure is rehab evaluation, getting that, like she talked about, the speech evaluation, but also OT and physical therapy. You'll find that even though after TPA they keep them in bed for 24 hours, your rehab group are still coming down to start their evaluation, right? Because otherwise they're moving these people along and moving them out, and that has to be done. Education, of course, you have everybody here is big as far as no matter where you are, going ahead and getting their education booklet to them, to the family, and starting to address different things within here as far as particularly identifying what is the risk factor for your patient. Was it sleep disordered breathing that precipitated? Was it high blood pressure? Was it a high cholesterol? Was it their diabetes? You know that you have to document and show that you have addressed the particular risk factors for that patient and start discussion on ways to prevent another stroke. So you start with the risk factors and go from there. Other things like calling 911, the symptoms of stroke, all those things have to be addressed. Now, as far as ischemic stroke, we're still talking about that. They have found out, I mean, as far as the evidence, is high-level evidence that for an ischemic stroke, within 24 hours, if you do not get TPA or endovascular therapy, then they will go ahead and probably give the aspirin in the ED. Have y'all noticed that happening? If y'all get a patient up, they will have gone ahead and given the antiplatelet therapy. And like I said, you can look at these other drugs, but aspirin stands alone. I mean, it's been researched, and whether it's 50 milligrams or 325, that's fine. All of those are a good prevention as far as another stroke. Control the hypertension, okay? This right here at some point before they're discharged, but during the initial phase, if they have not had TPA, then we'll talk about the high blood pressure shortly. Everybody that has an ischemic stroke needs to go home on a statin, okay? And the reason for this, it is shown that people that are given statins, that it will help to prevent another stroke. It's anti-inflammatory. It keeps that cholesterol down. They'll drive it down even lower, even if it's a normal cholesterol. It's advocated because of the anti-inflammatory and helping to prevent another stroke. Now, for your patient that has not had TPA or endovascular therapy, okay, those patients are allowed to have a blood pressure that goes pretty much to the top, okay? And so this is what the American Heart Association says. Permissive blood pressure up to 220/120 is allowed, okay? Now, your neurologist may differ a little bit on that, but still, for the most part, Drika, you all get them out on the floor. What's the highest? What is the highest blood pressure that you have received on the floor from the ICU on an ischemic stroke patient? Close to 220 or so, right? And you know, at first, nurses were really, I would have gotten, wow, what are we going to do about this? But when you do not have enough blood up there, then a high blood pressure keeps the perfusion going. So, not enough blood, high blood pressure. But at some point before they go home, within a period of time, then they should be addressing their blood pressure and reinitiate their antihypertensive therapy. One of the things we've had to be careful about is a hospitalist coming up and ordering to resume all home meds. You have to look at what is on those home meds because they may have been on 3 antihypertensive drugs. So if you restart the home meds, you know what you'll do? You will knock their blood pressure down and decrease their perfusion. So these are all your get with the guidelines. I think I've addressed the antithrombotic, which is given aspirin, the DVD prophylaxis, the thrombolytic therapy within 3 hours, the antithrombolytic aspirin or antiplatelet medicine by the end of day 2. If they come in tonight at 11:55, the end of day 2 is tomorrow night at midnight, okay? So this would be for the patient that has not had TPA or endovascular therapy. If they have had those, then you're going to wait another 24 hours before you give the antiplatelet therapy. Discharged on cholesterol-reducing medicine, screen for dysphagia, stroke education, smoking cessation, assessed for rehab, NIH Stroke Scale, and CT scan within 25 minutes. And you know that we do that number 12 usually a lot quicker than that. These are just some of the things from the American Association of Neuroscience Nursing. And this is just good nursing care all around. It's taking care of your patient's nutrition, preventing skin breakdown, bowel and bladder problems. Let me just address depression a little bit, okay? So we have a screening, and probably, I don't know, how often in ICU are they being screened for depression? Does anybody screen them in there at this point? Well, you all, usually who is it that does, who does your your depression screening, Adrika? Case management. I thought they were still doing it. But they just asked like 4 different questions, okay? It's pretty simple. You really cannot tell on these patients, I just tell you, who all necessarily is going to be depressed at this point, even if they do. But if they've already had depression problems, we need to make sure, even as they are in ICU, if they've been on antidepressants, that those things get restarted, because that can make a difference. 60% of your patients, after they go home, are going to be depressed, okay? So one of the things you need to address when you're doing particularly on your education, is just telling the family and the significant others that are with them and the patient, you may have your sad days coming up. It may not be this week or the next week. It may be after you go to rehab. But just to recognize that they're not necessarily having another stroke. They're just becoming apathetic, and they just need to be followed up with their primary care person, okay? Because with these symptoms of depression. But it is something that the Joint Commission hit us on last time, was how are we handling this? And what I gather in going to the stroke organization programs and everything, it's still a big issue of when should we and how should we do a better job in picking up on depression. When do you think your patient's going to fall? Most likely. On your watch in the ICU, or is it going to be after they get to the floor? Probably, I would think on the floor, because you can't be right there with them, and even if you got an alarm bed. But actually, particularly your patient that has that right hemisphere stroke, they're clueless about what they can do. They think they can get up and move, you know. So if you're not right there with them, their injury and falls are a big issue.